All right, so today we're going to talk about burns and the anesthesia implications of those. I will tell you from the start the two big things you need to pay attention to are your fluid replacement formulas and your burn percentage calculations. You will see those again and again and again. But with that in mind, you also need to be aware of the clinical implications of burns and how it affects your anesthetic plan. If you guys have any questions, let me know. We'll run through the PowerPoint, and then afterwards, there's a couple handouts we're going to go over and some reference material for you. All right, so first of all, there's several different types of burns. No matter what type actually happens, you usually see a combination of the two. Commonly, you'll have heat in conjunction with one of the other injuries, but the main types are heat, electrical, friction, chemical, and radiation. Fortunately, we don't see a whole lot of radiation or chemical burns. It's primarily going to be heat, electrical, and friction. So when you start looking at the depth of the injury, the most common things you have to worry about were how long were they exposed to that temperature. So if it's somebody, say for instance, that's trapped in a car on fire, they may have been exposed to it for quite some time. On the other hand, if you have somebody that touches like a hot burner or has something pulled off on them, it may not be in contact with their skin for quite as long because they either pull away from it or it washes off. On the other hand, like if you had somebody that had something kind of thick pulled onto them, it may stay in contact with their skin for quite a while, which increases the thermal injury time. Other things you have to worry about, the temperature of it. Low temperatures are generally not as bad as high temperatures, which kind of makes sense. And then the thickness of the skin. So when you start looking at what we call critical areas, even though it may be a small injury area, you have an increased risk of thermal injury just because of the thickness of the skin. So think about something that has a lot more sensitivity or thinner tissue like eyelids or the perineum. You may have an increased injury there even with a shorter exposure as compared to like, I don't want to say joints can also be problematic, but if you think about like a shin or a forearm, something like that, the skin tends to be a little bit thicker. So you generally don't have the same thermal injury that you see with sensitive areas or skin or thinner skin. Usually it involves the epidermis and the dermis. The most common types of exposures are going to be flame, hot liquid, hot solid, and steam. So when we look at electrical burns, the energy is basically transmitted and transformed to heat when the current passes through the body. So for some reason, somebody has completed the circuit, for a lack of a better word. They've inserted themselves into an electrical device, whether it's touching an exposed outlet, a power line. We see a lot of line workers that have injuries. They'll commonly be up in buckets and they'll touch a hot line or have something, and it generally transmits through them. You'll also see people after car accidents where they maybe have a down power line on their vehicle or it's on the ground around them, or maybe somebody doesn't realize it's a hot line and touches it accidentally. So usually what you'll have is an entrance and an exit wound, commonly and goes in a hand and comes out a foot, but not all the time. So what you usually see is that the energy is transmitted through that area. So you have to think about everything kind of between point A and point B. And they've not only had that thermal and electrical injury, but they've also had damage to their cells. So you'll see that they've disrupted their membrane potential, and their cells may not function quite the way they're supposed to. You also will have kind of cell rupture, so you start having elevated levels of potassium and several other electrolytes. Things that really come into play as far as the degree of the injury depend on the pathway of the current. So like I said, the most common thing is we touch things with our hands, so that's usually going to be your entrance wound. And then it generally grounds out through a foot or something else. So unfortunately, the vast majority of your body's in there. The other thing you'll see is that you touch it with one hand or you touch it with both hands and it transmits all the way through your chest. So a lot of times these people will have sudden cardiac events as a result of the electrical exposure. So it's pretty common for them to be in a VFib or VTAC arrest when this occurs. Other things that come into play, the resistance of the current flow and the strength and the duration of the exposure. So if you have somebody that's exposed to AC, generally it's a little bit easier on them, even at a higher voltage, because it doesn't maintain contact with the body A lot of times you'll see they're kind of blown back off of it. Whereas with DC, they tend to stay connected, for lack of a better word. So they have a consistent stream of current going through it. The other thing you'll see as far as electrical burns go is lightning strike injuries. You may see people outdoors. My sister had a friend in high school that was out playing softball, and clear day, they had storms like 10 or 15 miles away, and they kind of had a freak lightning strike, and it knocked down about half the team. And she went into sudden cardiac arrest as a result of the lightning strike and wound up brain dead. So it doesn't necessarily have to be electricity in the true sense of the word. You can also have exposure to lightning. The other thing you'll see sometimes is injuries to people in pools. Maybe there's an electrical issue there somewhere, lots of times lights or filters, something like that. Maybe it's not properly grounded. So you may see that causes an injury as well. And then you've got an electrical injury coupled with them being in the water. So a lot of times you have immersion injuries like drowning. And it's not easy to get them out. Usually you have to get the electricity turned off beforehand. Although sometimes you will see that the electricity is able to blow the breaker, and then you can get them out. But one of the big things to keep in your mind with electrical injuries, especially if you happen to kind of come up as a bystander, is your safety as well. That certainly applies to the other burns as well. But electricity is a little bit harder to see, so we kind of overlook that sometimes. Friction burns are a combination of mechanical disruption and heat generated by the friction. So they tend to be a little bit less severe. On one extreme, you have, think about like when you were a kid and you would do the Indian rope burns where you grab somebody's arm and twisted it around. They had a combination of the heat generated by it and then mechanical disruption as well from just the tissue being torn. But can go up quite a ways too. Other things you'll see are like rope burns. People may get ropes wrapped around arms, legs, something like that. And as it pulls, it not only burns, but also causes mechanical disruption of the tissue. And then it can go all the way up to motorcycle accidents. You have people that fall down, skid across the ground, that sort of thing. They'll have tissue disruption as well as some burning there. Chemical burns, generally it's caused by some sort of caustic reaction, and it really depends on the specific exposure what happens. But because the chemicals are generally either strong acids or strong bases, you have an alteration in the pH. It may just be on the surface, but depending on the chemical and the penetration, you may see that you have widespread disruption of the cell membranes as well as kind of direct effects on the metabolic processes. Um, the other thing that kind of comes into play here is the duration of exposure. So kind of the go-to for decontamination for a lot of these chemicals is going to be large volume irrigation and dilution. But for some things that may not be the correct answer. Some things may continue to burn even with irrigation. And kind of what happens depends on what the chemical was. Generally, acids will cause a pretty widespread necrosis that is a result of coagulation there from the exposure, whereas alkalis generally cause kind of a liquefaction, or basically turns everything into mush, which then leads to necrosis. It doesn't always hold true. If you're looking for specific treatment guidelines for these people, you can usually find that MSDS or the data sheet for the chemical itself, and it will tell you what you need to do as far as your initial treatment for these folks. But as I said, usually it's going to be irrigation. If it's a powder, a lot of times you'll start off by brushing it off the skin. Again, remember your safety as well, and then irrigate as much as possible. Radiation burns are a little bit different, and as I said, fortunately, we don't see a whole lot of these. Where they will come into play is people that have received intentional radiation exposure as part of cancer treatment. You'll see that they've had tissue damage. And you don't see so much the acute effects, but what you will see long term is the tissue becomes extremely friable. They're at high risk for tissue necrosis there. And you may see some localized burns on the surface there. Again, magnitude kind of depends on the dose and the time of exposure, as well as the type of particles they're exposed to. And the most common examples you're going to see are sunburns, which we don't even really count. But as I said, therapeutic radiation. You may also see that folks working in the nuclear industry have exposures. They're not very common, but it is certainly possible. And then one thing you always have to worry about is intentional acts. So think about like a terrorist attack where they've released some sort of nuclear radiation upon a population that can lead to burns as well as inhalation exposure. So how do we classify burns? This is a good chart for you to remember here, but a couple of reasons it comes into play is we've got to figure out how to identify burns that are important, those we really need to think about treating, and then those that will resolve on their own. The downside is you generally don't have a very clear-cut answer as far as burns go. And the other thing is they don't really declare themselves for about 24 to 48 hours. So what you see initially may not be what things look like a day or two later. They generally don't get better though. So if you've got somebody that looks like they've got pretty impressive burns to start off with, it's only going to get worse as it goes on. And you're going to have a mix of things. If you look towards the edges of burns, a lot of times they're not quite as severe, whereas in the core it may be a little bit more impressive. So you usually, as I said, have a mix of kind of deep and superficial sections. The elderly and pediatric patients will generally have deeper burns because they don't have the same amount of skin or the thickness of skin that adults do. So keep that in mind when you're looking at things. And there's a little just picture there for you to kind of think about what you're seeing. First degree burns are primarily just superficial to the epidermis. Second degree, you get down into the dermis. And then third degree, you actually get all the way down into the subcutaneous tissue. You may see people reference fourth degree, which is really where you start getting into muscle, bone, and sometimes they count that as a burn, sometimes they don't. Some people would just consider it part of third degree. But we're going to look at the burns themselves in a little bit more detail and kind of discuss how to identify the different injuries. So superficial or first degree burns usually involve only the epidermis. The skin should be intact. It's going to be red in color. Usually you have a dry surface without blisters. It's painful. A lot of the pain comes from that superficial layer of tissue. So deep burns are generally not as painful. So if you think about third degree burns, they usually don't hurt quite as much as second degree do. But as I said, you don't have that uniform layering throughout. So around the edges, it'll be extremely painful. So first degree burns generally heal themselves in 3 to 6 days. And one of the important things for you to think about when you start doing calculations for burn surface area, we don't count first degree burns. So we're only counting second and third degree burns when we start looking at injuries. So if you have somebody with first degree burns, don't include that. With that being said, it's kind of hard to skip over them, and you may see that you have somebody that had 20% burns the first day, and then you come back and look, and the second day, what you thought was just first degree burns is actually turned into second degree burns. So just keep that in mind. You don't include first degree. Second degree or superficial partial thickness. This is when you've gone through the entire dermis and or the entire epidermis and part of the dermis. Usually it's kind of got a mottled color to it. This is when you start to see blisters or weeping. So some of us have probably had sunburn in the past that was bad enough you actually had blisters. So you really had kind of a second degree burn there. These are very painful because a lot of times you're going to have exposed nerve endings. So it's really uncomfortable for people. The good news is for the superficial stuff, it'll usually heal itself within about 2 weeks without surgery, and you don't have a whole lot of scarring. Again, it kind of depends on what you're doing. And one of the things you have to make sure you do for these, because you do have exposed tissue, is make sure that you keep them clean. So if you've got somebody that's got blisters that have ruptured, they've lost part of that barrier to infection. So it's really important that you kind of take it easy, keep the tissue clean, keep it protected. So when you take somebody like this and put them into an infection-rich environment like a hospital, they tend to do poorly. So a lot of times if you have patients with smaller second-degree injuries, we try and get them out of the hospital as fast as we can, because otherwise they're going to start picking up infections in the hospital that may worsen their outcome. So you can see there you've got burns on the feet, burns on the ankle. One thing, just as kind of a note here, you can obviously tell the top picture is a child. We see a lot of burns that occur as a result of intentional injuries, especially in children. So you'll start picking up different patterns. One of the big ones is children that have been placed into hot water or hot baths. It may not be intentional, but it's always a concern and needs to be evaluated. So if you have children or patients that have symmetric injuries, be concerned that perhaps they have an intentional act. So like you see where they've got burns all the way up to their ankles, or you see where maybe they've got symmetric burns on their feet and their butt like they were placed into hot water. Be concerned that perhaps there was an intentional act there. Just a couple more pictures for you. As you can see, blisters are pretty common. And the other thing to look at is, as I was mentioning, a lot of times you'll see kind of a combination of second and first degree or second and third degree. As you get from the core further out, you tend to have a little bit less severe injuries looking at burns. So that's just kind of an example there on the right. So second degree burns, when you move past the superficial to the deep partial thickness, you see that this extends further into the dermis. A lot of times they have a decreased moisture level. So if you think about the ones we were looking at before, they looked very wet. I'm just going to flip back and forth here. You can see that they appear very moist. But when you look at the deep partial thickness, they don't have a lot of fluid there. It may be because they've already had blisters that ruptured, but usually what's happened is because of the thermal injury, they've almost had a localized loss of fluid there. It may have been evaporative, or they may have had an actual circulatory event where they pulled that fluid off. These burns are generally pale in color. So depending on the genetic background of the patient, they may be a little bit more obvious. Caucasians, you'll still see that a lot of times they're very white. So don't rely on that entirely, but you'll a lot of times see that they've had a pretty clear change in their skin color. You may also see that they've got patches. It may not be one specific area. You may just kind of have patchy areas where they've got deeper burns. The nice thing is with the deeper burns that they usually have a lot less pain because they have affected the nerve injuries. The other thing you'll see is, as I was mentioning, talking about the moisture, that since the sweat glands have been destroyed, you don't have quite as much fluid there. The other thing for you to think about is when we start talking about treatment for these patients, a lot of times they'll get skin grafts, but because of the injury there, they may not ever have any sort of return for their sweat glands. So you may see that the skin starts to become hot, but they're unable to sweat. So if you've got somebody with widespread second degree burns, you may see that they have a lot of trouble with heat exposures. And you'll see that if they go outside, they're required to wear like long sleeves, gloves, that sort of thing. These generally take about a month to heal and usually require skin grafting. The skin grafting may be quite widespread, especially if you've got significant injuries. Here's a couple other examples of deep partial thickness burns. You can see hands are one of the really big problem areas. As I mentioned, we tend to stick our hands into things. The other thing you have to think about when we start talking about burns is the area and its function. So areas that are kind of high risk or require referral to a burn center, usually joints, hands, fingers, toes, eyes, the critical 1% that we'll talk about in a couple minutes. But those things require a little bit higher level of care. Whereas, if something gets splashed on a forearm, they may require grafting, but it doesn't necessarily need to go to a burn center for specific care. All right, moving on from that to full thickness or third degree burns. And you'll hear it referenced both ways here. So you may hear it called full thickness. You may hear it called third degree burns. There's some variability from one place to another. So be familiar with both terms. If you have somebody with full thickness burns, the dermis has been destroyed. So think about the burn has gone all the way through the dermis there. Generally, when you look at the skin, it's dry, it's painless. You may see some actual charring. This is almost always going to require grafting. And the other thing you may see is the skin almost looks translucent. So you can see through it to the tissue and the vessels, nerves, musculature underneath. The one problem you kind of run into is the difference between deep partial and full thickness is very subtle, and it's a lot of times hard to tell. So if you look early on, you may not be able to tell the difference between one and the other, but for our purposes, it doesn't really matter. We're still going to include this as in our resuscitation formula. So whether it's second degree or third degree, it doesn't matter at that point. The other thing you may see is over time that they have no sensation for both of those, and you may lose elasticity. So again, it can be kind of hard to differentiate the two. These are some additional third degree burns. A couple things for you to pay attention to here. If you look at the picture on the right, you notice that it's kind of almost a splash pattern as opposed to something that was pretty clearly put in. But if you look down on his arm, you'll see that there's some continued stuff there. One area you kind of get into trouble with, if you have somebody that has hot liquids that have been splashed on them, poured on them, what have you, if they're not able to get those clothes off quickly, it continues to burn the whole time. So that may be problematic for them. So Not that you want to get burned with no clothes on, but it's a little bit less severe of a burn. If you look up on the top left, this is somebody that's getting a fasciotomy done. One thing to really pay attention to is even though they're using the electrocautery, notice there's not a whole lot of areas of bleeding. Again, you almost have a coagulation type syndrome that occurs there because of the thermal injury. So burns themselves generally do not bleed a whole lot when you have non-viable or burned tissue. What you will see is as you start moving down through the layers, like getting into the deep subcutaneous layer, you may start to have some bleeding or oozing. But while they may not bleed, they will ooze a lot of fluid. These wounds tend to be very weepy as they get deeper and start getting into the viable tissue. So they have huge fluid shifts, and that's one of the things we really have to focus on when we're taking care of these patients is their fluid status and what's going on. So this chart just kind of has a quick review for you. Remember, we only include partial thickness and full thickness, second and third degree burns for body surface area calculation. We don't include first degree. So how do we estimate burn injuries? There's several different formulas, and we're going to kind of go over them. But remember, you don't include your superficial burns. One of the most common ways for kind of lay folks to calculate this is what's called the rule of nines. So this breaks each body component up into a percentage. So your head is, and this is for adults to start off with, children a little bit different. We'll talk about that in a second. But your head's 9%. Each arm is 9%. Each leg is 18%. The anterior and posterior trunk are each 18%. And then, as I mentioned, the critical 1% are the perineum, because you do have loss of function if you have high risk burns there. So those add up hopefully to 100%. And what you'll see is that these are just estimates. I mentioned that it usually takes 24 to 48 hours for burns to fully declare themselves. So you will oftentimes underestimate burns initially, and then you'll see that a day or two later that they've got a lot higher burn percentage than you thought. The kind of caveat to that is if you don't have a lot of experience with burns, they can be pretty gruesome. So when you start looking at things, you may overestimate it just because you're kind of distracted by the injuries themselves. So we're going to flip to the next page where we've got the rule of nines. And this just shows you a breakdown of the percentages there. So head's 9%, anterior chest is 9%, anterior abdomen's 9%, 9% for the posterior of each one. Legs are 9%, anterior, 9% posterior. Make sure you know these. You will see these on your exam, and you will also see these on your certification test. So it's something that's going to keep popping up again and again. When you get to children, it's not quite as common for this to show up on test. And remembering the percentages is not quite as easy because they don't follow that rule of nines. But you have kind of some overriding themes. So if you think about it, children generally have larger heads and necks. So instead of just having that 9% head, now it goes up to 21%. To accommodate the shift in that, you have a little bit of increase in the arms, being 10% each. The back and abdomen actually dropped down because they were 18% on the adult, whereas the pediatric patient, they're only 13%. And then legs are a lower percentage as well because they're not quite as large. They still have the critical 1% though. So that's the rule of nines. And again, it just provides you with an estimation of burn percentages. The next method, which might be a little bit more accurate, is called the Palmer method. And this basically takes into account that the patient's palm is 1% of their body surface area. So it's, again, just a reference point for you. There's some other formulas out there, but so you can either just take their hand or take a piece of paper and kind of estimate as you move this around their body what percentage of burn surface area they have. They generally don't want to help you because they're probably not going to put their hand on their burned area, but it just gives you an estimate as you start moving things around. So problems you run into, if you have somebody with a very large burn surface area, we tend to underestimate that. Specific areas that we get into trouble with, women with large breasts have a larger surface area of their chest, which is not accounted for in the estimation formulas, especially if you're using the rule of nines. Obese patients, we tend to underestimate torso burns because it's a fixed formula. and they have a disproportionate percentage when compared to a traditional sized adult. So torso burns are generally underestimated, and because of their smaller proportion, extremity burns are overestimated. And the kind of displacement of the patient really comes into play too. So as you think about gynecoid versus android, it can be a factor for you. All right, so we're going to move on a little bit from estimating, talk a little bit about the pathophysiology and what actually happens in these patients. And as you start looking at these injuries, you kind of have two conflicting priorities. So you have shock, but you also have edema. So what you see is that they develop a relative hypovolemia and decreased perfusion because they've lost so much plasma out of their microvascular into the interstitium. So instead of having the fluid intravascular where we really want it to be, it starts to kind of weep out into the tissue because of increased permeability. So they have a relative hypovolemia. They've lost that volume that's circulating. But at the same time, all that tissue has started to become edematous, which can lead to its own problems. These are dependent on the patient, their pre-existing conditions, and the degree of the burn surface area. So big things that come into play when you start looking at fluid losses is the burn size and the patient's weight. If you have somebody with about 20% or higher total burn surface area, they tend to develop burn shock or that hypovolemia and need to go to a burn center or an ICU to get monitoring and resuscitation, especially if you have high percentage burns. So like think third degree full thickness burns, especially as they approach that 20%, they probably need to go get specialized care. The other thing is these tend to be very painful. So monitoring and treating the pain in these patients can be problematic for you. So if you can get them to one of those tertiary care centers that does offer burn resources, they may do a little bit better. So it's a very fine balance for patients because over resuscitation and under resuscitation each come with their own consequences. Consequences of under resuscitation include decreased perfusion. One of the first things we really worry about here is the kidneys. One, because they tend to be underperfused if you have that relative hypovolemia, and two, because you have so much muscle injury, you have a lot of myoglobin and contaminants that get into the kidneys and tend to bind them up, which can lead to a kidney failure. Outside of that, you can also have any sort of end organ failure you can imagine, lungs, liver, but kidneys tend to be the most susceptible just because of that kind of combination punch of the byproducts as well as the hypoperfusion. When you start talking about over resuscitation, this was kind of something we skipped over for a long time. If we had patients with burns, we just push fluid, push fluid, push fluid. And we figured out over time that perhaps we were doing them a disservice by just giving too much fluid. So in younger patients, too much resuscitation generally leads to abdominal compartment syndromes. Older patients, because of maybe pre-existing comorbidities, tend to have pulmonary issues. So one of the common things you see for high percentage burns is that they tend to get intubated pretty quickly and stay that way for usually about a week or so as they kind of move through the initial phase of this burn injury where they have so many fluid shifts going on, they have so much edema. Remember, if you're seeing edema in the peripheral tissue, you're probably seeing it in the lungs as well. All right, so a couple of things that happen as far as metabolic response to burns. You almost have an autocannibalism. So think about your body kind of starting to eat itself. We oftentimes under nutrition or under treat the patient's nutritional requirements. We're getting better about that, but for a long time, anesthesia has really been part of the problem for nutritional impairment in these patients. So what you'll see is that we're very fixated on our MPO times. Burn patients usually go back to the operating room daily, if not twice daily, for debridements and skin grafting as they get a little bit further down the line. But as part of that, we commonly want to make sure that they're not getting any sort of tube feeds, diet, any of those sorts of things, because we start worrying about the risk of them aspirating. On the other hand, as we do that, we're neglecting their nutritional needs. So what you'll see is that these patients tend to have a loss of fat. They lose their lean body mass either through being bedridden or the auto cannibalism that's going on. So to try and compensate for that, you have a gluconeogenesis, and that is trying to take advantage of whatever is there. You will also see a lipolysis. And so you've got that on one end where you've got kind of poor nutritional status. And then on the other end, because of the burn injuries, you have a hypermetabolic state. So these patients tend to have increased metabolism, heart rate's going to be elevated, blood pressure is elevated. Because of the fluid shifts, they may be hypovolemic. So to compensate for that, you'll see the metabolic rate and the sympathetic drive goes up even higher. And then the other thing you'll see is because of this metabolic response that they tend to be a little bit resistant to insulin. So it's pretty common for these patients to be hyperglycemic. So that's something else you kind of have to keep in mind as you start treating these patients. Factors that come into play for the metabolic response, again, going back to intensity and duration. So the significant size of the injury, the degree of pain. If you have somebody that's comfortable, they tend to not have quite the same metabolic response that those that are in pain do, which makes sense. So one of the big things from our perspective is getting these people comfortable and keeping them comfortable. A lot of times in the past, we've relied on opioids. They may get PCA infusions, but we've moved towards more regional anesthesia for these patients. So you may see patients have nerve catheters placed and maintained for the duration of their hospitalization, just to help out with reducing that metabolic response because of the pain. The other thing you'll see is ketamine gets used pretty widespread in these patients, which seems somewhat counterintuitive because it may increase their metabolic demands, but because it is such a diverse agent and helps out not only with pain, but also a little bit of sedation, and doesn't necessarily decrease the respiratory effort and blood pressure, you kind of have to take trade-offs for things. The other thing you'll see is you start getting into really high percentage burns, so like 40% total body surface area, the metabolic rate doubles, and this pattern continues for months. So it doesn't necessarily stay that way just while they're receiving care. If you see these people go home, you'll see that they kind of maintain that auto-cannibalism for quite a while afterwards. Other things you see along with it, they tend to have immunosuppression. As part of that, they may wind up with recurrent infections and poor wound healing. So it's important for us to kind of chase after those sugars to make sure that their glycemic balance is maintained. Try and reduce whatever infection risk you can. Because of the nature of these injuries, a lot of times they've been exposed to stuff that can cause infections. And then we bring them into the hospital and they stay there. So a lot of times they get secondary infections that are really the problem. So just things for you to think about there. So from a carbohydrate standpoint, what you'll see is that they have increases in cortisol, circulating catecholamines, and glucagon. So think about all those things elevating your blood sugar. So it's not uncommon for these patients to wind up on insulin drips to try and maintain that. You will also see that they've got an accelerated hepatic gluconeogenesis, which contributes to the peripheral insulin resistance. It's generally related to the extent of the burn, but not 100%. Sometimes with those kind of high surface area but lower percentage burns, you may not see this happen. Whereas if you've got kind of higher depth burns in smaller percentages, it does tend to happen in those patients. And this can last long periods of time, up to 3 years. So from a lipid standpoint, you generally have an accelerated lipolysis. This may also be due to direct tissue injury. So there's not really an easy way to look at it, but if, again, you have increased depth of burns, you have that increased lipolysis, whereas just because you have an increased body surface area burn doesn't necessarily mean it's going to happen. One of the kind of go-to treatments for this is beta blockers, and what you'll see is that helps decrease the lipid oxidation and the metabolic rate. So you may see these patients are on PO, beta blockers. They may be on atenolol is commonly used, as well as metoprolol. So depending on the medication, it'll usually be on the lower end, but don't be surprised if you come in and you find that your burn patients are all on some sort of beta blocker. From a protein standpoint, you generally have an accelerated proteolysis of the skeletal muscle. This is, again, twofold, because these patients are generally bedridden. So they're not having kind of the muscular demands that you commonly see. And then you may also see that as a result of direct tissue trauma. So when you have those severe burns or high depth burns, a lot of times they'll get into the muscular layers. Other things that come into play, you'll see that the degree of stress tends to affect the degree of loss. So higher stress tends to result in higher areas of loss. So if you've got somebody with severe burns, it's generally doubled. If you've got somebody with high cortisol levels, you may have issues there. And you may see that the interleukins are able to mediate some of that, but that can actually worsen things for a lot of these patients. So we're going to kind of shift from what's going on to how do we manage these patients. And this is really when it's going to come into play for you guys. Just looking through your questions real quick. So I don't know really the extent of exposure you guys have to dealing with burn patients. They can be really challenging, and a lot of times they have other issues going on. We're going to talk about most of those other issues today, but you may have traumatic insults. You may have people that have been in explosions. Common ways that this happens, depending on where you are, meth labs cooking off. So you've not only got an explosion, but they also tend to get burned. Plus they have substance issues. They may be acutely intoxicated. Gas leaks are another big one. I can think of several times where there were gas leaks and houses blew up and people were burned. So you've not only got the burn, but you've also got explosions. You may see these occur in house fires where maybe they were inside the house for a long period of time and they were not only exposed to the burn, but also part of the toxic chemicals that were given off through the burn. So you may have somebody with a toxic exposure, say for instance cyanide, on top of somebody with an elevated methemoglobin level or a carboxyhemoglobin that's elevated. Or you may have somebody that's been in a car accident. Maybe they were pinned in a vehicle that was on fire. So these can be really complex cases to manage. The straightforward ones, for lack of a better word, are usually the people that do dumb stuff like pouring gasoline on fires, which if you're in a trauma center, you're going to see that happen pretty frequently. So they go to pour gasoline on fires, it flashes, it usually travels up the path to the gas tank or whatever they're pouring it from. Or, the container itself explodes and then everybody gets splashed with burning stuff. So those are kind of the common ways you see this. So flipping through your questions. I did not see the Grey's Anatomy episode, but I'm glad you were prepared. ER had an episode back in the day that was pretty gross for burns. TV generally dramatizes burns a little bit worse than they are. But with that being said, on TV, you don't have the smells and the exposure that you do. I know Wynn brought up an explosion in Barksdale a couple months ago, but I can think of lots of burn patients when I was in Shreveport and Galveston as well. When I worked at the ER in Galveston, we would actually kind of help with the initial debridement in the burn unit. So it was pretty common that if you had a burn patient, you'd be in the burn unit for an hour or two afterwards, helping with the debridement. Shreveport was a little bit different. Really, our exposure there was kind of taking him to the OR. And then sometimes we would do the initial intubation. Depending on where you go, the flow is a little bit different from one place to another. So, for instance, in Galveston, the patients would come into the ER there, be stabilized, and then go to the burn unit. In Shreveport, the patients would usually go straight to the burn unit and be stabilized there. The exception to that was those patients that had a lot of kind of outside trauma. But because of the nature of burn injuries, those patients tend to get referred to the burn centers. So they've usually gone to another hospital and then they get transferred for specific treatment of the burn. So hopefully they've stabilized whatever the underlying issue is. Tyler, we're going to go over the specific burn center requirements here in a little while, as far as what you need. And it really depends on the patient and kind of what's going on with them specifically. Other things, Richard brought up the peds. So down in Galveston, in addition to the adult burn center there, they've also got a Shriners Burn Hospital. That was actually supposed to be my first nursing job out of school, but somebody with experience took it, so they didn't want the new grad. Katie asked about fireworks. I worked like 6 Fourth of Julys in a row, and I can tell you so many funny and bad stories about fireworks. Needless to say, it's almost like snake bites because people are almost always drunk. They're doing stupid stuff, and then they either blow up in their hands, they shoot them at somebody, but they get burned, they blow off fingers. There's a meme somewhere out there that it's like July 3rd, and they're like, this is somebody's last night with all their fingers. Aaron asked, would a higher fat protein nutrition be preferred for these patients over carbs? It really depends on the patient and their activity. The problem you run into is a lot of times this come together. So you have higher fat with the carbs. If you have somebody that's able to tolerate PO, you may be able to break it down, but usually they're going to kind of come together. And protein is one of those things that's kind of hard to convey to some of these patients, especially through the liquid diets. So we would really like to get them nothing but protein if possible, or mostly protein, but it's kind of hard to do that. All right, so moving on to initial stabilization, and there's a lot of factors that come into play for these patients, but things that we really focus on, respiratory support, because we're anesthesia and that's what we do for people. Fluid resuscitation is probably the biggest factor that comes into play for these patients. We've talked about the inability of them to compensate for fluid injuries and fluid loss. And that goes hand in hand with the cardiovascular stabilization. So if you have somebody that's profoundly hypovolemic from a cardiovascular standpoint, they're really going to struggle. So you've got to evaluate the patients for their fluid resuscitation and think about everything that's going to be affected by this. Because of demand ischemia from the hypovolemia, you may see these patients have almost MI or cardiac events. So that's definitely something you have to take into mind for these patients. Again, one of the big things we worry about is pain control for these patients. And even though opioids have kind of been the long hallmark of treatment, we've moved on to other things. As I mentioned, ketamine is pretty common, as well as peripheral nerve blocks. And then localized care of the burn wounds. So you'll see these patients generally go to the operating room daily, if not twice daily, for debridement of the wounds, especially when they first come in. You may also have patients that come in for almost more of a clinic type atmosphere. So instead of being inpatients, like I said, we try and get those low burn percentages out of the hospital so they're not exposed to secondary infections, but they may need to come back in for debridement. So you may see some of these patients that have gone home with the lower percentage burns that then come back in for outpatient procedures for debridement. Again, secondary stuff, these are really the important things we worry about. You see pain controls up there again because it's such a big issue that we run into, but we've got to manage their pain. Other issues you come into play, especially because of the decreased vascular status, make sure they're on some sort of thromboprophylaxis so they don't wind up clotting off. Depending on what stage they're at, you may be able to use mechanical devices or you may have to look at some sort of chemoprophylaxis. Again, chemoprophylaxis may be problematic because now you've got somebody that was already oozy and may be bleeding and now they're bleeding more. On the other hand, blood clots are probably bad. Mechanical prophylaxis may be difficult because of the burns themselves. So the last thing you want to do is have somebody that's got extremity burns and now you're putting an SCD over top of it. With that being said, you will see a lot of these patients have TED hose in place that helps reduce the peripheral edema, but it may actually lead to some sort of restrictive flow that can cause problems as far as clotting. We try and get them in for wound closure as soon as possible. When you have that exposed skin, it tends to lead to infection. So if you're able to fix that quickly, the patients tend to do a little bit better. I already talked a little bit about nutritional support, but it's really important for us to consider from an anesthesia standpoint, maintaining that nutritional support as long as possible. So if you have somebody that's already intubated and maybe they even already have a PEG tube or an NG tube in place, please try and continue that tube feeding as long as possible because without that nutritional support, they're not going to be able to heal. Other things, trying to control that hypermetabolic response. So we may use beta blockers. We may try and manage their pain. Both of those really come into play to try and reduce that metabolic response, which is going to increase all those demands. Things we can do to prevent infection. So antibiotics are not commonly used in these patients. We'll talk about it in a little bit. But part of that is that we try and prevent them from getting infected. But after they're infected, they tend to require kind of high doses of antibiotics and not really routine stuff. Other things that come into play when you start looking at these priorities are associated injuries. So you may have kind of conflicting diagnosis. You've got somebody with pretty significant burns, but they also have a closed head injury. So which is more important, resuscitating them for the burns or not over resuscitating them, resulting in elevated ICP? Spinal injuries can be problematic because if you've lost that vascular tone because of the spinal injury, coupled with the relative hypovolemia from the burns, they tend to require more and more fluids. The other thing you'll see is a lot of times those patients will be placed on some sort of vasopressor to result in vascular constriction to help maintain that integrity so they don't have quite as much oozing and leaking. You can have fractures associated with burns. So, I mentioned the motorcycle case. It's somewhat common for people that lay bikes down that they tend to break things too. So you may have burns at the site of the fractures as well. And then same thing, if you've got somebody with chest and abdominal trauma, it can be conflicting priorities as far as resuscitation because you may have something that's going to kill them quickly, like the chest or abdominal trauma. And then you're also worried about what happens long-term for those patients as far as resuscitation and infection from the burns. All right, so pain control, we talked about some of the common things, but one thing you want to keep in mind for these patients is trying to get to a steady state. So what we try and do is put them on scheduled long-acting medications. So instead of using common like opioids, we'll put them on longer-term stuff. If they're able to tolerate PO, we may go to long-acting PO opioids. If not, you may use IV methadone. It's also available PO, depending on your patient. And like I said, we're trying to essentially maintain a steady state for these patients. So if we can put them on something that keeps them comfortable for long periods of time, you help reduce that hypermetabolic state that they encounter. Other things, non-opioid, consider acetaminophen, ketamine. You may supplement with anti-anxiety drugs. So part of this is concern about what's going on and reducing that metabolic state. So you may see these patients are also on like Ativan or Valium. Midazolam's used sometimes for intubated patients, but usually for long-term stuff, especially PO, we're going to do Valium or Ativan. Other things for breakthrough pain, a lot of times we'll put these patients on PCA infusions. So they may be getting long-acting PO stuff, but they may still, because of movement or some sort of issue, have breakthrough pain. So we usually try to provide them with a PCA or something else for some comfort. You may see these patients are on long-term ketamine infusions. Again, your anti-anxiety medications may come into play there as you start worrying about some of the long-term psychological complications of ketamine. Or the ketamine may be reserved for kind of stimulating things. Hey, we're going to give you a bolus of ketamine before we move you around in the bed, certainly before dressing changes. Another thing for you to think about, not all these patients go to the operating room for dressing changes, especially if you have somebody that's in a burn unit. A lot of times they'll do dressing changes at the bedside. So it's almost like a mini operating room. So those patients, again, will need kind of increased analgesia for that. A lot of times ketamine's used in that setting. You may see that your PK and PD is actually altered in burn patients. So you may have to evaluate the patient's response to things. It may be totally abnormal. You may be giving doses that you thought would be toxic to somebody, resulting in respiratory depression, and it doesn't touch them. Or on the other hand, just because of the state they're in, you may be giving normal doses that kind of have an exaggerated response. So you really have to kind of feel these patients out and figure out where they're at. That's one of the nice things about keeping them in that steady state is you don't have big swings, because you'll see those big swings tend to be where you get yourself into trouble. All these medications should be going either PO or IV. IM medications don't absorb real well, especially in burn patients. You can certainly use them as a last resort, but don't count on them being reliable. So as I mentioned, fluid needs are one of the really big things we have to worry about. So we're going to talk about this for a little bit. And what you see with the burns is that it causes an impaired endothelial layer. Because of that, the barrier is essentially lost. You'll also see they have increased capillary permeability, so they tend to ooze everywhere. You'll see these people laying in bed and everything's just saturated. They may need those beds changed a little more often because of that. The other thing is that because of that fluid loss, they tend to not stay very warm. So you've got to do things that are uncomfortable for us, like keeping the burn unit really warm. For big guys going down to the burn unit, it's kind of a nightmare because you're not only down there and it's really hot already, but then you're going to put on gown to help reduce the infection risk. But you do what you got to do for your patients. Time in the burn OR can be really rewarding, but from a physical standpoint, it can be kind of exhausting because you're hot, you're sweating, you walk out of there and you're soaking wet. Even people that don't sweat on a normal basis. So that's something else for you to think about from your personal perspective. But you tend to lose intravascular oncotic pressure. Again, you see all those intravascular fluids that tend to weep out, and they tend to have that relative hypovolemia because they've lost all that intravascular fluid. Other things that are going on, you have a widespread inflammatory reaction. So patients tend to do kind of poorly as that inflammatory reaction grows and grows and grows. So things for you to think about from our standpoint, medications you may want to avoid in these patients. Etomidate's a big one. We know it causes adrenal suppression, so it may be problematic for that inflammatory response. Other things you'll see is they have a widespread release of histamine, prostaglandins, and cytokines that cause vasodilation. So it's really like the perfect storm for your vessels because you're losing intravascular volume, you're weeping out everything, the vessels are dilating. So they can be very difficult to maintain. Like I said, a lot of times we'll put these patients on some phenylephrine to help cause or counteract that vasodilation. So you may see a combination of things used. And then on top of that, they're getting fluid resuscitation. So fluid resuscitation is primarily aimed at patients that are greater than 15% body surface area. Again, it depends on where the burns are and the depth. If you've got critical burns or like pulmonary burns, they may be very difficult to assess. So it really depends on the patient, but that's kind of an estimate for you is 15 to 20%. So how do we resuscitate these patients? Usually we're going to start off using a basic formula. We're going to talk about some of those. But then we want to kind of transition to goal-directed stuff. And when we get to that trifold afterwards, it really helps you out as you understand your treatment priorities. Issues that we run into with these patients that get overhydrated. So we talked for a long time about how it's important to kind of make sure you effectively resuscitate these patients. But if you give them too much fluid, it can also be problematic. So you can result in pulmonary edema, and one of the big ones is abdominal compartment syndrome. A lot of the research for burns, again, comes out of the military. It actually comes out of San Antonio. But what they figured out is they had these healthy young guys that were having large-scale burns. They were getting resuscitated with perhaps too much fluid, either intentionally or accidentally. And they were doing fine with their burns, but they would make their way back to San Antonio at about the 24 to 48-hour mark. And by that point, they'd been over-resuscitated, and they had this huge abdominal compartment syndrome, and they would wind up not dying from the burns, but from dying from the dead gut. We see the same thing happen on the civilian side. We just don't have the concentrated area for research. So keep in the back of your mind that giving too much fluid can also be just as bad as not giving enough fluid. So how do we estimate resuscitating our patients with fluid? There's a couple different formulas to follow, and we're going to talk about this. The Parkland formula is one of the most common ones. Funny enough, it's not used at Parkland anymore. They've moved on to a little bit more technologically advanced formula, but this is probably still the most common formula you're going to see. And this is really just a starting point for where you go with your fluid resuscitation. So it's really for just the first 24 hours. If you have certain burns, like electrical burns or inhalation burns, they can be very difficult to assess because nowhere on that chart of body surface area did you see inhalation burns. But if you think about the huge surface area of the lungs, they can be, exceed the rest of the body just by the size of the surface area that's there. And there's no estimate for it. So those critical burns can be very difficult. Electrical burns may require higher volumes because the muscle and tissue destruction, which tends to lead to that renal failure. And the other thing that kind of comes into play, we look at this as we're standing there when this happens. So from the time of injury, we start doing our calculation. What happens if this patient goes someplace else, or they go to the emergency room and they're not adequately resuscitated? How do we make up for that lost time? Do we try and get more volume in? So there's not really a good answer for some of those sorts of things. But you may see that those patients, because they were inadequately resuscitated, actually wind up requiring higher volumes. But at the same time, you still have to worry about over-resuscitating them. So like I said, these are good references for the first 24 hours. Other things we look at as far as how well resuscitated our patient is, urine output may be beneficial. Depending on which formula you look at, usually it's going to be a half to 1 ml per kilo per hour. The second day, I talked about this is just for the first 24 hours. That second day, you may consider adding in small amounts of colloids, especially albumin, because it helps with the intravascular integrity, and it may even help reduce part of that edema. The one thing you have to be cautious in these patients with albumin is you do increase the risk of renal failure. So you can kind of have a double-edged sword. You want to get volume in there. You want to use the volume that's already there, but at the same time, you don't want to pull any fluid away from the kidneys. So how does the Parkland formula work? There's a couple different components to it. So what you do is start off with the patient's body surface area. So you've got to be able to calculate that. As I said, you can use your rule of nines. You can use your Palmer method. You can just do quick estimates. If I look at a patient, it seems like half their body is burned, I may just call it 50%. It's not a real specific thing, especially for us as we start kind of estimating resuscitation for patients. So you'll see some variability for the actual Parkland formula. A good reference point for you is going to be 2 to 4 mLs per kilo times the percentage of body surface area, with half of that volume given over the first 8 hours and the other half given over the next 16 hours. So we're trying to get that fluid resuscitation in to start off with. So let's say we have a patient with 50% body surface area. So we're going to start off with 4 mLs times 50% times, we'll say they're 100 kilos. So in that 24 hours, we want to give 20 liters of fluid. So we're going to give 10 liters over 8 hours. So for that first 8 hours, our fluid rate's going to be 1,250 mLs an hour. And then the next 16 hours, you would give 625. Other things that kind of come into play when you're looking at that, though, as I mentioned, urine output, and then those variables, inhalation burns, electrical burns, delayed resuscitation. Those sorts of things are also used for kind of calculating stuff. All right, just flipping over to look at questions. Katie asked about steroids to help decrease the cell membrane permeability. A lot of times we don't use steroids in these patients just because of the increased infection risk. So as I mentioned, they tend to have trouble with their insulin resistance, so they're hyperglycemic. And a lot of the research has shown that the steroids don't actually help. It seems like it would, but it not necessarily. Now, with that being said, you'll also see some local variability. Burn surgeons specifically tend to kind of follow regional patterns. So they've trained at Hospital X, and this is what Hospital X did, so they take it with them. So you may have seen that some are used, but it's not a common treatment method. Magali asked about placing, I think, an IVC filter. You may see IVC filters placed, but it's not real common initially. But if you have somebody that's going to be bedridden for a while, they would certainly try and get those in just like they would for any other bedridden trauma or medical patient. Sorry, I'm trying to read Tyler's post. I'm going to go over kind of a better reference for you that's a little bit more straightforward, Tyler, as far as the resuscitation formulas. There's quite a bit of variability from one place to another as far as what they do. So I'm just going to give you some examples. You're really not going to see anybody that's going to test you on burns outside the first 24 hours because there is so much variability. I just want you guys to be familiar with the concepts you're going to have to face after that. So first 24 hours is really just going to be figuring out your burn percentages, getting them adequately resuscitated. Usually it's based off a total body weight because that's the actual tissue you're dealing with. But I'll say that to you, and then somebody will say, oh, no, it should be off of ideal body weight. But when you start looking at fluid status, it's the actual tissue that's there. So even if somebody should weigh 100 pounds, if they weighed 300 pounds, you've got to perfuse that 300 pounds. All right. So do you guys understand the math for the Parkland formula? So 2 to 4 mLs per kilo times percentage of body surface area, half of it over the first 8 hours, the other half over the next 16 hours. All right. So we're going to hop from that to kind of an easier formula. I personally prefer this formula from a math standpoint. It's a little bit easier. And with that being said, Parkland is probably more common on the civilian side, but I'm not sure it's actually better. But it's just a reference point for you. So for an adult patient, you're going to take 10 mLs per hour times their total body surface area that's burned. So if you had somebody with 50% total body surface area, you would multiply that times 10. So they're getting 500 mLs per hour. If they weigh more than 80 kilos, you're going to add 100 mLs per hour for each of those per 10 kilos. So if they're 90 kilos with that 50% burn, they'd be getting 600 per hour. If they're 100 kilos with that 50% burn, they'd be getting 700 per hour. So like I said, this formula is just a little bit easier. Doesn't require quite as much math. But Parkland is probably the more common formula that's utilized. So if you were just to study one, I would make sure I use the Parkland formula. For pediatric patients, it's 3 mLs per kilo times the total body surface area. And that's your volume for the first 24 hours. Again, it's just like Parkland, where half of it's over the first 8 hours, the rest over the next 16. All right. So hopping over, well, actually, do you guys have any questions about fluid resuscitation? Because that's something you're going to see on your test. That's something you're going to have to do. So if you have any questions about any of those things, please let me know. We're going to do some practice stuff. And when we flip over to the trifold at the end of this section, it's got some good reference stuff in there for you as well. Let's take a 5-minute break. So take 5 minutes and come back, and then we'll get into kind of the anesthesia side of things. All right, guys, we're going to pick back up where we left off. Clarissa asked for the Army formula. TBSA is the total burn surface area. So it's not their body surface area like everything, it's just the burn surface area. All right, so moving on into specific anesthesia management cases. As you can see, these burns can be quite widespread. And as part of that, you may see these patients come back to the operating room time and time again. You almost develop kind of a bond with some of these patients. You get to know their families. You get to know a lot of what's happened as far as their specific event, because you do see them multiple times, every week. And they're usually people from your community too. All right, so from a preoperative standpoint, important things for us to figure out. We need to be able to estimate the burn surface area, determine the severity of the burn, because we need to be able to calculate whether or not this is a severe burn or a superficial burn. And then the other thing is that we need to think about who needs to go to a certified burn center, because even though you don't work in a burn center, you will take care of burn patients. A lot of community plastic surgeons and general surgeons will still do burn care. And they're usually going to be patients that fall outside of this criteria. But with that being said, the kind of boundaries change over time. So you may see people that are pushing their limits. So what patients need to go to a certified burn center? The first one is full thickness burns over about 10%. High voltage electrical injuries. I talked about how complicated they can be. Chemical burns, especially widespread chemical burns. Inhalation injury. Inhalation injury can be extremely difficult to manage. We're going to talk about that specifically here in just a little bit. And then kind of critical areas. So face, facial burns that are disfiguring can be very problematic. Hands and feet. If you think about somebody that winds up with a bad burn to their hands and feet, they can lose function, and that can be devastating. The critical 1% in the perineum, and then major joints. If you don't have your joint burns managed appropriately, you can again have loss of function. So those are the big criteria for referral to a burn center. Some places may have additional stuff, but those are the big things we look at there. Other things, so you need to figure out where they stand from a fluid resuscitation standpoint. So if you're, a week out, you're not really in an acute resuscitation phase. On the other hand, if this is somebody that's coming to the operating room for their first debridement, or maybe they're going to the operating room for other injuries, you want to see where they stand from a fluid resuscitation standpoint. So you need to calculate where they should be and then figure out where they actually are. Other things for you to keep in mind is kind of a goal-directed perspective. So look at their urine out point. See how much fluid they've had in, how much they have out. We have this bad habit of doing what I call fluid creep, where we just give a little bit more. We'll give a little bit more. And then you go back and you look, and everybody's given a little bit more. And all of a sudden, the patient's edematous and has complications because of that. So let's talk a little bit about the fluid itself. We prefer lactated ringers for almost all these patients. You do have a risk, especially with saline, of hypernatremic, hyperchloremic acidosis. So we prefer to stick with LR. Usually you're going to titrate this every hour according to the urine output goal. But that doesn't necessarily hold true. Some places they use non-invasive monitoring. Some places they may look at using CVP. This may be one of the very few good indicators or good uses of CVP. But again, it can be problematic just because of the loss of tissue integrity and vascular integrity. You may not get an accurate measurement. We try not to give fluid boluses to these patients because, again, just like with the pain management, we're trying to get them to steady state as far as fluid resuscitation goes. So if you're dumping fluid into this patient as a bolus, the body is not able to deal with that well. You're much better off just increasing your overall fluid rate than giving them little bumps of fluid. From pediatric standpoint, if they're over 40 kilos, go ahead and use the adult formula. On the lower end, same thing, 2 to 4 mLs per kilo of LR times the total burn surface area. If they're less than 20 kilos, I would consider adding some sort of maintenance fluid like D5LR as well. And just like you would with your regular maintenance fluid for pediatric patients in the operating room. Same end goals. You're going to titrate to urine output of 0.5 to 1 ml per kilo. So now we're going to talk a little bit about colloids, specifically albumin. So for that initial period, we want to try and focus on crystalloid-based resuscitation for these patients because albumin is not necessarily as straightforward as you think it is. But if you're getting to 8 to 12 to 24 hours post-burn, or you've got somebody that's getting large amounts of fluid at that point, so think about like 1,500 mLs per kilo, or if you've calculated that when they get to 24 hours, they're going to be exceeding 250 mLs per kilo, think about starting an albumin infusion on these patients. And this is just a reference table for you. Again, when we get to that trifold, it really breaks it down for you. But this just kind of gives you an idea of how much albumin you would run in. It's calculated based off their weight as well as the total body surface area. Now, this has ranges. The slide that Tyler put up had a specific formula. I don't think either one of those is necessarily wrong. It's really just going to come down to kind of the institutional practices there. Pediatric patients, generally it's going to be weight-based for the albumin, 4 to 7 mLs per kilo, and you're going to infuse that at a half ml per minute. And what you'll do is over time, if you see that you're starting to use more and more albumin, you want to start cutting back on the crystalloid by an equal amount. So if I'm giving 50 mLs of albumin an hour, I want to reduce my crystalloid infusion by 50 mLs per hour. For adults, this isn't quite as important because they're generally not getting quite as much albumin and they're getting a very large volume of crystalloid. Pediatric patients tend to be a little bit more prone to being fluid overloaded quickly. So that's why you want to try and trade one for the other. So when you're doing all this fluid resuscitation, you have to kind of think about their cardiac status. So you see two kind of distinct phases. So the first thing during that initial resuscitation phase, we kind of have what we call the ebb phase of the cardiac output. So cardiac output is going to be very low, primarily due to that relative hypovolemia from the capillary loss. So you see that they don't respond to catecholamines quite as well. You may see increased systemic vascular resistance because of the circulating vasopressin levels, or you may see because of the release of the histamines and prostaglandins that you have peripheral vasodilation. So it really just depends on where they fall into that time frame. As part of that low flow state, you may see that they have that demand ischemia that I was talking about, so demand myocardial ischemia, because they're getting inadequate coronary flow. If their flow is poor everywhere else, it's going to be poor to their heart as well. So make sure that you've adequately resuscitated them. Then on kind of the back half of this, when you get to 3 or 4 days out from the burn, you have what we call the flow phase. So at this point, all that fluid has gotten there. They're maybe teetering on being over-resuscitated. So you have a very high cardiac output. They're tachycardic. You see that because of that increased metabolic status that you have increased myocardial oxygen consumption. SVR may be decreased. This is one of those times where you want to think about making sure that you've managed your pain well, and you also want to start thinking about beta blockers at this point. So it's really kind of a two-part problem as you address where the patient falls into that. The other thing for you to keep in mind, patients don't read the book. They don't know that this is what they're supposed to be doing at this time. So you may see that people transition from the ebb state to the flow state a little bit earlier. Just stop and look at their clinical picture and decide what you need to do for them. So from a pulmonary standpoint, you have a widespread systemic inflammatory process right after the burn. It can lead to pulmonary hypertension because they're trying to perfuse their pulmonary capillaries. You may see that the capillaries themselves have membrane rupture. So as part of that, you may have fluid leakage into the lungs themselves. You're going to have decreased plasma oncotic pressure. And because of all this extra vascular fluid in the lungs, you're going to have a hard time ventilating these patients. So things you have to think about, maybe increasing PEEP. It's pretty common for these patients to be on some sort of bronchodilator therapy. Because of that extra fluid in there, they tend to be predisposed to bronchospasm. So if you think about it, the extra fluid in there tends to lead to those bronchi closing off. So you may have to do something to keep them dilated, or like in the case of PEEP, to keep them open. You'll see a restrictive lung defect in these patients, and it can come from a couple different things. But the biggest one we worry about is that they've got circumferential burns to the chest, which is resulting in physically limited extrusion of the chest. So they can't move their chest up and down. One of the things we really have to watch on these patients is our airway pressures. So as they started getting more and more fluid over time, you see that tissue become more and more edematous. And because of the burns, it's not able to expand out with that tissue inflammation. So the only thing it has to do is creep in on the lungs. And the definitive treatment for these patients is going to be escharotomies. So if you have a patient with circumferential or full thickness chest burns and you're having a hard time ventilating them, you're probably going to wind up having escharotomies done, which is pretty straightforward. It can be done at the bedside. It can be done in the operating room, but it will almost instantly fix your problem for you. So from that, we're going to move into inhalation injuries. We talked about them being pretty common with fires in closed spaces. So like I mentioned, in houses, in cars, that sort of thing. Kind of symptoms we looked for, singeing of the face or nasal hair. So if you look and they've got kind of black soot around their nose, you open their mouth and you look in and their tongue is burned. You may see soot actually in their mouth. From a laboratory standpoint, you can get a carboxyhemoglobin. Some of us are able to get those on our point of care ABGs, and you may see your carboxyhemoglobin level is greater than 10%. Assessment wise, you may hear that they're wheezing. And finally, if you're really wanting to move on to confirmation or you're in doubt, you can always do a bronchoscopy. Usually, if we have somebody that's presenting like they have an inhalation injury, we're going to go ahead and treat them as such. If we are a little too aggressive, it's a lot better off than being under aggressive on these patients and losing an airway. So commonly with inhalation injuries, we see facial burns. One of the hallmarks of these and kind of one of the anesthesia nightmare scenarios is this extensive facial edema. So there's a lot of things that kind of come into play here. You've got large amounts of facial edema. You may have significant edema of the tongue. You may have swollen structures inside the airway itself all the way down to the glottis. So that's why we try and intubate these patients early on if they have facial burns, because when things start swelling, they become extremely difficult to get the airway into place. So when you start thinking about securing your endotracheal tube, it can be problematic. Because of the facial burns, tape generally will not work. Sometimes you will suture these tubes in place. Another common thing that's used is twill tape, and they'll wrap it circumferentially around the face. And then you may also see that they use those commercial tube devices that have a sticky part, but they also have a strap that goes around the head. The one thing you have to pay a lot of attention to with these patients, if you put something circumferential, make sure you're going back and reassessing it. Because if you have something that's really tight and then they start to swell, you may be the one that's actually causing impaired tissue perfusion because of that. Other things, think about the eyes. If you look in their eyes and realize they have contact lenses, try and remove those. The downside is if they've had a significant facial burn and they had contacts in, a lot of times those contacts will melt into place. So you may want to get ophtho to come see them either way. But certainly if they've had contacts in place that have burned. On the face, you're going to use bacitracin ointment to the eyelids. Remember, I told you those thin tissues tend to do poorly. So you want to try and treat them as well as possible. And then inside the eyes themselves, a lot of times we'll put some erythromycin ointment to help out with infection post-burn. All right. Quick look at the questions. Richard asked about 5% albumin or 25%. It's going to be 5%. Kira asked about memorizing TBSA and pediatric isn't as important for testing purposes. The big thing I would do is just learn the Parkland formula, and you can apply it to pediatric patients. After you get outside that first 24 hours, there's some variability. But as far as questioning, you're probably just going to run into adult questions, but be familiar with the concepts that change with pediatric patients. So, the head gets bigger, the extremities get less important. You may have to calculate a pediatric burn percentage, but it's probably just going to be an adult one. That's why I said it's a little less important, but know the concepts that change when you go from an adult to a pediatric patient. The chances of you having a pediatric burn patient you have to calculate are pretty low, but it could certainly happen. But with that in mind, if you know the kind of changes, you should be okay. All right, so we talked about carboxyhemoglobin. One of the things that patients inside enclosed fires get exposed to is carbon monoxide. And it's kind of a exposure-based diagnosis until you can get a carboxyhemoglobin level. But things we really think about: fires in enclosed spaces, people with improperly vented gas and oil heaters, commonly associated with suicide attempts, engine exhaust. It's confirmed by carboxyhemoglobin levels. But the other thing you have to keep in mind is that it may not be straight carbon monoxide. You may see that there was something burning, like plastic, that was giving off carbon monoxide as well as cyanide. So your treatment of these patients is usually going to be based off of a carboxyhemoglobin level, but you may have to treat them prophylactically based off of what happened. Primarily treatment is going to be oxygen and then cyanocobalamin. So back to the nutrition issue. A little bit further down the line, you kind of have to start thinking about what's going on with these patients. Again, we talked about the insulin resistance. And what we've kind of figured out is, I said that anesthesia may be part of the problem. If you've got somebody that's already intubated, please let them continue their tube feed to the operating room if possible. It's not always possible. Maybe you're turning somebody prone or something that makes them higher risk for aspiration. Maybe this isn't an intubated patient. But if they do have enteric feeds going and they're intubated, consider letting them keep going throughout the operative process. So pharmacologic standpoint, you do tend to see a change in your plasma protein concentration. Remember that a lot of our medications need that protein for traveling. So if you've got somebody that's got a very low protein level, you may consider supplementing them, and you may also see delayed effects just because of that low concentration. You may also wind up with a lot more medication sticking around longer because of that decreased plasma concentration. Other specific things we worry about are acetylcholine receptors, and we're going to talk about those because that's a big one you see. And one of our medications can be very problematic for those patients. And then again, depending on where they're at in that ebb flow state of cardiac output, think about your onset time for medications. So if you're in a state where you've got delayed cardiac output or decreased cardiac output, you may see that your medications take a little bit longer. At that point, we tend to get a little bit antsy and want to give more medication, but that could be the wrong answer because you wind up overdosing your patient. So looking specifically at acetylcholine, we see this upregulation of receptors after burns lasts for quite a while, maybe as long as 2 years to recover. So as part of that, we need to figure out who we can give medications to and who not to give medications to. One of the big ones we worry about for that patient population is going to be succinylcholine. So if you have somebody with a history of burns, especially in that first 2 years, you probably want to avoid giving succinylcholine. The caveat to that is if you have a fresh burn within the first 24 hours, you're probably okay to go ahead and give succinylcholine. So after 24 hours and up to about 2 years, you probably want to avoid succinylcholine for those patients. And the reason for that is that they tend to have a significantly marked increase in their serum potassium levels if you do give them. One of the weird things is it doesn't correlate with the severity of the burn. So just because somebody has a low burn percentage doesn't mean that they won't have a significant response to succinylcholine. Another thing you see as part of the upregulation is that they do have a little bit of resistance to non-depolarizers as well, especially when you get to this kind of higher percentage like 25, 20% burns. It may take additional non-depolarizing medications to work. So a big takeaway from this is no sucks after 24 hours, okay? So intraoperatively, things may change a little bit. You still need to have the same kind of monitoring requirements, but they may change. From an EKG standpoint, you may have to move your electrodes to a different place. So because of burns, you may not be able to put your traditional stickers on there. You may also utilize staples and alligator clips. So it's basically what it sounds like. You're going to staple the skin and then just put an alligator clip on there that will then plug into your electrode spot on your cable. If you're someplace where they do a lot of burns, they usually have these available to you. Other things you have to think about, your pulse ox probe. Pulse oxes may not read real well through burn tissue. You may also not want to put a sticker on a burn because it hurts. So you may move it someplace else. You may go from fingers to ears, mouth, toes, those sorts of things. You may have a hard time getting an accurate measurement because of carboxyhemoglobin levels. Non-invasive blood pressure cuffs may be accurate, they may not be accurate. Because of the tissue edema and surface burn areas themselves, you may transition to an arterial line. Again, those are going to be sutured in place. And one of the kind of weird things for these patients is they may not actually have dressings over top of their burns because of the areas of the burns. You can certainly insert needles and lines through burns. They can be more problematic for you, but you definitely want to make sure you secure it somehow. So make sure they're sutured in place rather well. And you may suture them at multiple places as opposed to just being at the site. From a laboratory standpoint, consider using base deficit as an alternative to lactate levels if you don't have that available. Or you may just use your base deficit as kind of a guide for how under-resuscitated you are in these patients. So you can look at urine output. You can also look at your base deficit. Stroke volume variation can be helpful. Whether you have that set up with a flow track or something like that, or you're doing a non-invasive cardiac output, any of those sorts of things can kind of come into play for those patients to help you out. Temperature, we can't talk about this enough. You can lose up to a degree of Celsius temperature every 15 minutes. So make sure you're using kind of convection warming devices, warm the operating room, warm your fluids, all those sorts of things. We're going to talk a little bit more about specific things here in a minute, but do everything you can to keep that patient warm. And then keep track of your urine output. So make sure you've got a Foley in place for these patients. Make sure that you've gone back and looked to see where their urine output trend has been. Or have they been adequately resuscitated from a fluid standpoint? If not, you may be paying catch up for part of your case. This one got out of order somehow. I'm not sure how the airway assessment wound up here instead of back with the airway stuff. But so this is kind of a classic airway burn picture. There's a pretty good chance he's got an inhalation injury. When you look at his face, you obviously have soot on his face. You have singed facial hairs. If you've never burned hair, that's what it looks like. It kind of shrivels up. So how do people get in this situation? One of the Darwinian ways that we see this happen, and I thought it was like a one-time thing until I kept seeing it. How do patients wind up on home oxygen? They wind up on home oxygen because they smoke. And somewhere there is a disconnect between the fact that they are now on oxygen because they can't breathe and their need to continue smoking, and the fact that oxygen doesn't do real well with flames. So pretty commonly you will see people that smoke and people that are on oxygen, and they decide to do both at the same time. So it's basically like putting a flamethrower up your nose, and you see this kind of presentation here. So as you can see, you've got burns to the nares, you've got some burns to the face, you've got some burns to the eyes, but pretty clearly he's got a inhalation injury. He's got airway burns in all likelihood. So this is somebody you're going to want to get intubated as quickly as possible. Other things for you to think about, hoarseness, wheezing, shortness of breath. We talked about the carbonaceous sputum. If you've got somebody with nasal burns, they may have singed hair to their nasal hair. They may have singed facial hair. You may have pretty significant facial burns. And as I said, it may not happen immediately. You may see it 24 to 48 hours out. If you've got somebody that's got a high overall percentage of body surface area burns, it's a pretty good likelihood that they've also had airway involvement just by proximity to whatever was going on there. So that's definitely somebody I would consider intubating early. And this is the why of why we would consider intubating them early. So when you look here, you see how swollen the glottic opening can be. It's really hard, especially when you're younger on in your career, to figure out where the tube needs to go in these places. And tissue just becomes more and more edematous over time. So if we're able to get that tube in there while we still have something that kind of resembles trachea, it's better for us. Similar situation with epiglottitis. If you can get this tube in quickly, it's better for the patient. When you look to the right, this is showing you somebody with pretty significant airway burns. As you're looking down to the carina and further into the bronchi, you see that the soot has actually made it all the way down there. The other thing is, especially when you look at that image labeled C, notice how dry that is. That's not a traditional airway. There's no moisture there at all. So you may see somebody that actually has soot there, or you may see something more like the lower images where they've just got red inflamed tissue and a little bit of soot. Both of those are kind of bad indicators that they've had a pretty significant inhalation injury. This is just other examples for you. When you look at the patient's tongue and there's black stuff on it, that's a bad sign. Other things you may see, and I put these pictures here that are kind of grotesque for you to understand the magnitude of it. You may be intubating somebody that's going to die if you don't get them intubated soon, but it's kind of a grotesque thing for you to be in proximity to. There is nothing wrong with covering the patient's face or covering up whatever you don't need to see while you're intubating these patients so you're not distracted. Because it is really a big physical and emotional response when you see something like this, especially if you haven't been around this sort of thing before. So there's nothing wrong with putting a burn drape or a towel over somebody's face while you intubate them, just so you're not distracted. Other thing to see here is kind of examples of how they've secured the endotracheal tubes. You may see these patients are nasally intubated. You may see them orally intubated. For a long time, we did nasal intubations because we would do them while they were awake. With the increased availability of fiber optic devices like the GlideScope and that sort of thing, we don't do quite as many of these as awake nasal intubations as we used to, but you may still see that happen. So airway management, somebody that you're really worried about impending airway obstruction, stridor, hoarseness, dysphagia, these are signs of a response, not necessarily just what's happened. So, when you look at them and you see their face is burned, that's bad. But when they've gotten to the point where they become hoarse, they become stridorous, this is somebody that needs to be intubated quickly. They can be very difficult to intubate, especially with significant edema. Other things you may see because of contractures or eschar, you may not have a whole lot of mobility of their neck. So sometimes they have to do escharotomies prior to intubation to increase your mobility, or you may see that you have to use a fiber optic scope to be able to place the tube, just because it's problematic to be able to get it in with a traditional laryngoscopy. Patients may be very difficult to ventilate with a bag valve mask because of the burns or because of burn dressings in place. So you try and reduce the amount of time you spend ventilating these patients. They will almost always be either an awake fiber optic or an RSI, trying to get that tube in place. You go back and forth about what's the best approach for the patient, and it really depends on what you see. We may try and preserve spontaneous ventilation for this patient because it's a little bit better for facilitating gas exchange. And it may also be a little bit easier or safer to get them intubated while they continue to breathe. Finally, securing the endotracheal tube. The patient may get intubated initially and then move on to a trach. Things you can use to secure it, the cotton umbilical tape, like I said, make sure if you do something circumferential that you're reassessing it so they don't wind up with constriction. Sometimes we'll suture the tube in place. Sometimes we'll wire it to their teeth. LMAs are not a good choice for any of these patients because they have a whole lot of issues. Whether it's the pulmonary issues or the airway itself, you want to make sure that you've got a patent airway in these patients. So from an intubation standpoint, propofol may be okay. You just have to stop and look where they're at. If they're in that ebb phase, it's probably not a good choice. On the other hand, if they're in that flow phase where they're kind of hyperdynamic, propofol may be beneficial. Etomidate is probably not a good choice for these patients just because of the concern about adrenal insufficiency. Ketamine may be good, but you've got to look and see where they're at. If they're already kind of hyperstimulated, ketamine may not be a good choice for them because they may not have a whole lot of sympathetic reserve, or they may already kind of be in overdrive. We do use this pretty commonly, like I said, for dressing changes. The other thing you may see is using a combination of medications, so ketamine and fentanyl, ketamine and propofol. You can also use opioids for induction, but again, look and see where they're at in that ebb versus flow state and see how well they would do with it. So hemodynamic instability for these patients is primarily due to hypovolemia. Usually they have lost their preload, so you see decreased cardiac output. It's pretty common to see this happen, but if we early resuscitate this patient, they will generally do okay. I'm going to see if I can get this image to come up. library's always getting in the way. Are you guys able to see that? This is just a T showing you kind of a normal volemic patient versus a hypovolemic patient, looking at the left ventricle. So you can see that black area there. That's the ventricle itself. Notice how it's kind of nice and full on the normal volemic patient, whereas when you flip to the hypovolemic patient, it's kind of hard to see. Um, so just an example for you. And you can also see how greatly it affects the squeeze because there's not enough volume there. So just something for you to think about there. You may see that a TE is a good monitor for these patients because it does allow you to see in real time what's going on, but just something for you to think about there. All right. Other things for you to think about in these patients, they may have multiple events going on. So if you take an older patient that's been burned because of the stress, they may, develop some ischemia. On top of that, you start adding in demand ischemia, and they may have an MI. Other things, especially if you've got like polytrauma or other stuff going on, think about other types of events you may have to treat. So one of the things you have to think about for these patients, even though they don't lose a whole lot of blood initially, you will see that, especially as they start undergoing surgical procedures, that you will lose some blood. So kind of a formula, if you really want to think about it, generally they're going to lose about 2.6% of total blood volume for every 1% of burn excised or graft that's harvested. So when you actually watch a skin graft, they try and do everything they can to reduce the perfusion at that area. So usually what they'll do is infiltrate with lidocaine with epinephrine, which helps out with the pain. It also vasoconstricts so they don't bleed as well, but you'll still have some oozing there. So in these patients, usually if they're getting low or anemic, start thinking about transfusing them if their hemoglobin gets down to about 7 or 8. If you've got somebody with cardiac issues, you probably want to keep them about 10. Other things they do to help reduce that blood loss, as I mentioned, topical thrombin. So they may put something on beforehand. They may infiltrate epinephrine. Instead of doing big skin grafts, they may do staged procedures. So they do a little bit, come back, do another little bit. Other things you may see, the use of Nova 7 may be beneficial to reduce the risk of bleeding, but it does obviously increase your risk of thrombosis. And likewise, TXA may cause an increased risk of thromboembolism, but it may reduce the risk of bleeding. So it really depends on the patient. So when you start looking at these patients, they can develop shock for a lot of reasons. If you see that you're administering an appropriate amount of fluid for these patients and they're not resuscitating, you may need to consider bridging them with some sort of vasopressor. So vasopressin or norepinephrine may be beneficial in the short term. We want to try and get as much fluid as we can into these patients, but it may not work fast enough, and you want to keep them alive while the fluid's working. As I mentioned, CVP may be useful in this situation. Goal of 6 to 8. If you're not at goal, you may consider increasing your fluid rate by 20 to 25%. Again, this is just an estimate for you, but it may be a beneficial use for CVP. So I talked about infiltrating lidocaine with epinephrine prior to doing these skin grafts. This is what we call tumescent use of local anesthesia. So generally the way they mix it is going to be a gram of lidocaine with a variable amount of epinephrine, sometimes up to 1 milligram. And then they're going to add 10 MEQs of sodium bicarb to speed the onset. And usually they put it in a liter of fluid. But everybody's got their own little recipe. But one thing you really need to take away from this is the understanding that it's not just lidocaine that's in there. It's not just epinephrine. You may have bicarb in there as well. But you also have to account for all those medications going into the patient. So if you have somebody that perhaps you're already running on a lidocaine infusion for pain, now you got to stop and think about, hey, they just give this patient a whole lot of lidocaine. The max is kind of a hard thing to assess because it's not IV. You don't have the same systemic absorption. So 55 milligrams per kilogram is kind of a rough maximum, but there is quite a bit of variability. Just kind of gives you an idea. The nice thing about doing this, you have decreased blood loss. It makes it easier for them to excise granulation tissue. It reduces surgical times. And generally, because you've added the epinephrine in there, you don't see the hematomas and the bruising postoperatively that you would otherwise. So thinking about mechanical ventilation for these patients, if you don't have any sort of traumatic injuries preventing you, go ahead and elevate the head of the bed up to about 30 degrees. Think about where you're ventilating the patient. You may want to hyperventilate them just a little bit. So CO2 on a little bit lower side. Part of that is because they tend, especially if you've got some sort of restrictive pathology going on, to become hypercapnic. So you want to make sure that you're keeping your CO2 a little bit lower and your pH adequately. Before you do anything with these patients, make sure you're adequately pre-oxygenating them. So for instance, if you're going to suction this patient, adequately pre-oxygenate them and then suction them. The other thing you may see, just because of the extent of bronchial injuries, is that these patients may wind up with lots of clots in their lungs, and you may have a hard time actually getting that suctioned out. So one of the things you may consider adding to this is nebulizing heparin. So usually what we'll do for that is add 5,000 units of heparin in with the 2.5 milligrams of albuterol and do that about every 4 hours. So as you start doing that, it'll help you get some of the blood up out of the lungs. And this is just kind of showing you an example of those patients that may be beneficial. What you'll see is that they tend to have like ulceration or sloughing of the airways on bronchoscopy. So if you give the two of these together, they work out pretty well. If you just give the heparin, one of the issues you run into is because they're not bronchodilated, as those tissue chunks and clots are moving through there, you have an increased risk of bronchospasm. So definitely think about doing the two of them together. And if I had somebody with airway burns that I was having a hard time ventilating, I would probably consider this. So we talked a little bit about abdominal compartment syndrome. Basically what happens is the abdominal pressure displaces the diaphragm up because the bowels have become so edematous. The primary diagnosis for this is going to be bladder pressure. If you have a burn patient that gets to the point of having abdominal compartment injury to the severity where they have to open their abdomen, they've got about a 90% mortality. So this is something that you've got to be very careful about and keep in the back of your mind as you're doing your fluid resuscitation. So how do we do the bladder pressure monitoring? Usually it's going to be measured about every 4 hours if you've got patients with higher percentage burns, so 20 or higher. If you've got a bladder pressure greater than 12, start thinking your patient may have intra-abdominal hypertension. If their pressure is greater than 20, that's consistent with abdominal compartment syndrome. So those are definitely things that you need to be monitoring and thinking about with your larger percentage burn patients. One of the things that's kind of a trade-off here, for a long time, we did large volume fluid resuscitation as kind of our hallmark of treatment for these patients. And what we figured out through the military's experience in theater was we may have to accept that the kidneys are going to take a hit and stop fluid resuscitating these patients before we give them abdominal compartment syndrome. So the trade-off for that is you'll see these patients being put on short-term hemodialysis because their kidneys are suffering, but we're not giving them all that fluid. So they don't wind up quite as edematous as they would otherwise. So you may see that being kind of a trade-off depending on where you go. Some places still flood all these patients, but probably the best practice, if you get it to that point where you're giving albumin, you've got them on a vasopressor and it's just not working out real well, you may want to consider that the kidneys are just going to take a hit and think about dialysis for those patients. Usually not something we have to worry about, but it's definitely something you want to think about just in the back of your mind. You may be the one that brings it up to discuss it with the trauma surgeon They may already be thinking about it, but they haven't looked at the patient in the same perspective you have. Sometimes a fresh set of eyes is a good thing. All right, so post-operatively, uh, mechanical ventilation can be problematic. If you've got somebody with inhalation burns, they're at risk for ongoing bleeding. So this is kind of one of those issues where heparin may be good, it may be bad. The other thing is if you've had somebody that's had extensive debridements, fasciotomies, escharotomies, they may continue to ooze. So start thinking about what happens next. So like I said, a lot of times these patients will come back to the operating room every day. So you want to make sure that you're not setting yourself up for failure the next day. Get these patients adequately resuscitated, keep them adequately resuscitated, and kind of follow along with it. Other things to keep in mind, like we talked about, DVT prophylaxis, making sure the beta blockers are in there, keeping them warm, keeping them adequately nutritionized, I guess. So this is kind of a funny, kind of not funny. There are really no good pain scales for burn patients. So there's not like a go-to scale. You see there's quite a bit of variety there. Sometimes we're happy, sometimes we're crying. But just try and use consistency from one to the next. Postoperatively, these patients will almost always have kind of present background pain. So scheduled medications are good. As I mentioned, anxiolytics like lorazepam or Valium may be beneficial. Consider additives for painful things, so like debridements, dressing changes. As the kind of analgesia expert, you may be consulted to help out on these things. Other things that may be beneficial, we'll have some patients that will utilize nitrous oxide through a handheld mask. So that may be enough to help get them through burn changes. Some places they do that for labor epidurals as well, or in lieu of labor epidurals. Peripheral nerve blocks may be beneficial, especially for patients that are going to be here long term. But one of the things you have to keep in mind for these patients is how are you going to approach that area? We generally try not to instill catheters through burned areas if we can help it, but maybe there's someplace else you can go. I talked a lot about thermoregulation, but these are just some examples of things you can do. There's a couple different kind of traveling packs, if you will. It could be as simple as putting blankets on a patient. It could be as simple as a bear hugger on a blanket. Certainly any fluids you're giving you want to warm. Another thing for you to think about, depending on where you work, burns are one of those tenuous situations that you may get involved in taking the patient from point A to point B by virtue of you kind of being the resuscitation expert. More than once, I've been at a little hospital and wound up flying to a bigger hospital with a burn patient because they were concerned about losing the airway. Maybe they had already intubated them and they're having a hard time ventilating. As EMS services have gotten better, this isn't quite as commonly used, but you never know. You could run into a situation where you've got somebody that's having to go by ground because of weather and they want to send you along. Burn patients are one of the few times that's really happened to me. So things for you to think about there. If they're going outside in an aircraft, it's cold. If they go up to altitude, it gets colder. If they go outside in an ambulance, it's cold. A lot of times those things have the air conditioner blasting so everybody's comfortable. This patient that doesn't have skin anymore is not going to do well with that. So think about how you package your patients up and kind of your plan for what ifs, how can I keep them warmer? Do I have portable equipment I can use to keep my fluids warm? Just little things like that. Extremities, a lot of times what we'll do is kind of prop these up on pillows, and that just helps with dependent drainage. As the extremities start to swell more and more, we want to make sure we're checking pulses on these patients. They are at high risk for compartment syndrome. So if pulses are palpable, that's great. If not, go ahead and Doppler them. If you have patients that have significant swelling either of their limbs or of their chest, you may have to do escharotomies. Kind of our reliable check for extremities is going to be pulses either by palpation or by Doppler. For the chest, we're going to start thinking about when we start having ventilatory compromised or increased airway pressures, or it's getting to the point where we've got enough pressure on the heart that our cardiac output's decreasing. So what is an escharotomy? An escharotomy is literally cutting through the eschar, or the burn tissue. If you look at the picture on the right, it kind of gives you a reference point for where we usually perform escharotomies. And basically, you're just allowing that extremity or that chest to swell. So it doesn't impede flow, it doesn't impede ventilation. And this is just a temporary thing. It's just like patients that have fasciotomies, they can be dressed and closed. Other things for you to think about, kind of adjuncts. Make sure the patient is on some sort of GI prophylaxis. They're high risk for stress ulcers. If you have any lines, please make sure they're sewn or stapled in place. Tape and dressings are not adequate or reliable in this patient population. As far as burns to the genitalia or perineum, try and make sure you get a Foley in quickly, because as they start to have swelling, you may lose your urethral patency, and it may be very difficult to get the catheter in there. The good news is, while scrotal swelling may be really impressive, it usually doesn't require any sort of specific treatment. Other things, they need to make sure they get their life-saving tetanus shot. So if they haven't had one in 5 years, please get that in there. Most of the time, the emergency room's taking care of that. A lot of times, we don't use IV antibiotics for these patients initially. If they become infected, it's another story, but we generally don't give prophylactic antibiotics or steroids for these patient populations. As far as dressings go, one of the most common things that gets used is Silvadene, which is a topical antibiotic. It's kind of a white cream. We can use that pretty much everywhere except on the face. It will cause facial discoloration on the face. You're just going to use bacitracin. Other things you may see used, there's some silver sulfate dressings that looks like kind of a mylar blanket they'll lay over things. Those help with wound healing. They may use moist dressings to help keep the patient warm. And you may also see that silver nitrate is sometimes used on specific areas to help with stopping oozing or bleeding. This is somebody that's actually going through skin grafting procedures. So you can kind of follow the progression up there and see where they're actually overlying the grafts on these patients. Graft size may be restricted by a couple things. Usually it's the surface area. Sometimes they'll do an autograft where they take the patient's own skin, or they may use donor skin, or they may actually even use some of the porcine skin to try and graft the patients. But again, quite a bit of variability there. But these are patients that are going to have to come back to the operating room multiple times for things. All right, so there's a couple references for you. I'm going to hop over to a couple of the things I showed you guys. Let me see what you guys have for questions. Yes, people smoke with nasal cannulas all the time. I can't tell you how many times I've seen it. Tyler asked about any worry with the endotracheal tube balloon when you have burns that go super deep into the bronchus. One of the important things is you need to make sure you're monitoring your cuff pressure. So usually you want to maintain that cuff pressure 22 to 26. So in a perfect world, the respiratory therapists are checking that. We don't live in a perfect world, so you may be the one that figures out that this patient's cuff is overinflated, they've got elevated pressure, but that's what it should be. Some places, when you intubate the patient, it's your responsibility to check the cuff pressure. Some places you just document it. All right, so I'm going to bring up a couple of these things I put in for references. The first one is that burn trifold I kept mentioning. If it'll open. Sorry, the computer apparently has to verify my Microsoft Word for some reason. All right, so while it's doing that, I'll talk about a couple of these other things you can look at here. So this is the lesson content. There's a couple of useful things here for you. This burn care pocket guide is the one we're getting ready to look at together. Other things, this anesthetic management of patients with major burn injuries is an article from the ANA journal, just talking about kind of anesthetic management. A lot of it's stuff we went over today in just a little bit more depth, but if you're looking for some good reading, that's not a bad place to turn to. The basic burn care guidelines just goes over some treatments for burn patients that you may find helpful. Let's see if it'll open. So this is from the Army or the Military Joint Trauma System. If you're ever looking for kind of guidance on trauma care, the CPGs from the Joint Theater Trauma System are really beneficial. So this talks about a lot of different information in depth. But if it's something you're not real sure about, and I mean everything is available here, but this kind of takes you through step by step burn care um, from the time it happens all the way into the hospital. So those are all kind of helpful things for you to consider when you start looking at your burn patients. But they've got a wealth of information on there that you can look at. Talking about burn formulas, securing tubes, resuscitation, and this is constantly updated. So you may see that something that you were taught today has already changed because they do constantly update these things, and it's really the latest and greatest information available. They also talk about specific problems. If you've got somebody with low urine output and they're hypotensive, start this medication, think about this. If you start talking about antibiotics, inhalation injuries, a lot of these things are just in great detail here. So that's a great reference point for you. It is apparently going to be difficult today. This one goes a little bit further into kind of prolonged burn care. So this makes you think about things after the initial 24 hours. So as you start thinking more about pain management, infection, and that sort of thing, it's pretty helpful for you. As I said, this is just an article from the ANA Journal talking about anesthetic management of burn injuries. A lot of it's kind of a review of what we talked about today, but there's some helpful information in there. This thing will not open. All right, let me try quitting Word and opening it again. Yeah, thank you. Carissa posted the link to the CPGs. Like I said, it's great information for anything trauma related. There's other stuff on there too, but the big thing is trauma. That's kind of the cutting edge stuff there. This is not one to open. Let me see if I can find it another way. All right, I'm not sure why my Word isn't working. But when you look at that, it's really a restatement of the CPGs kind of put in one place for you. So it guides you kind of through the decision process as far as do this, I can put up albumin, and that sort of thing. All right, do you guys have any questions from today? All right, if you guys don't have anything else, since my Word is not working, that's all I've got for today. As usual, I'll get it posted for you.